Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites and our monthly edition of my favorite program, Show Me the Science. Show me the science. Hey, today we're diving into the tricky business of predicting the future. If you've been around me, you know I'm really good at that. Specifically predicting whether or not someone is going to get dementia. Now, that's a tough subject. Doctors are not soothsayers, though, and my medical degree does not grant me the power to see into the future. That's why instead of precise predictions like, you will get dementia, we often use the word risk. As in, you're at a higher risk of developing dementia or whatever XY disease it may be. Now, there are many different tools aimed at predicting someone's 10-year dementia risk. That is, how likely are you to get dementia over the next 10 years? And these are called dementia risk scores. Basically, these are different kinds of algorithms that account for numerous factors like age, sex, wealth, medical history, etc. The problem is, in their current form, they're not very predictable, and they're not very reliable. A large cohort study published this last summer in JAMA Network Open looked at 4 of the most commonly used risk scores and followed up with patients a decade later. The dementia risk scores only predicted between 9 and 16% of the dementia cases that developed. The risk scores missed 84 to 91% of dementia cases. The study authors concluded current risk scores have limited clinical utility, which is a long way of saying your physician, based on our current criteria, can't really tell how much of a risk you are. So how can these risk scores improve? Can we say for someone is at risk of dementia? And if so, should patients, providers act on that information? And by the way, what can we tell our patients to help minimize their risk no matter what their score is? Today, we're joined by Dr. Jeff Burns, a neurologist specialized in memory care and the co-director of the University of Kansas Alzheimer's Disease Research Center. And if you've been on this program many times, you'll know that Dr. Burns is a bit of a frequent flyer. Also, Jessica Calendar-Rich, a geriatric medicine specialist helping older patients stay healthy as they age. Geriatric meaning she takes care of old folks, kind of like me. Later, we'll hear from Dr. Dana Hawkinson, Doc Hawk, to talk about COVID, flu, and RSV. And we'll also hear from Jill Chadwick. You'll remember Jill, she kind of runs the whole place back down here. And she recently took a test aimed at detecting signs of dementia. Oh no, how'd she do? Lots of different things are linked to dementia. For example, high cholesterol, depression, low physical activity, alcohol, social isolation. Ooh, some things that came about during the pandemic for a lot of folks. Dr. Burns, if we know about all these links, tell us why it's such a challenge to predict who's going to get dementia and who won't.
Yeah, so that's a complicated question. And I'll try to give you a simple answer, but it is really hard to predict who's going to get dementia, and we are working really hard to do that because we see a future where we're going to be able to predict who's going to get it with some reliability and then do something to reduce that risk or stop that risk. But it's hard because there's a lot of risk factors for dementia and Alzheimer's disease, many, and you just mentioned some of them. And they're weakly associated with dementia, and they work together in ways we don't really understand to cause that risk. And it's hard to know, so if somebody can have all those risk factors and not get dementia, and somebody can have none of those risk factors and still get dementia. And so, so a lot of factors that are weakly associated, and then they work together in various ways. And then people have resilience. Some people have a lot of resilience to these risk factors, and some people don't. And we're beginning to understand those factors. So there's some more fundamental problems as well, such as defining what is dementia in practice and in our studies, and then defining when does it start. And these are sort of practical, sort of fundamental questions at the study level that can really blur how we do things and how we measure things. And so all those things sort of work together to make it hard to predict who's going to get dementia and when.
Okay, so I got some more questions about some of that. So we're going to come to you in just a moment, but I want to go now to Dr. Jessica Calendar-Rich. Dr. Calendar-Rich, when you see a patient, do you do an individual risk assessment for dementia?
Yeah, so when I see a patient, I actually take a lot of information about how they are, how they've been, and sort of try to figure out the trajectory of how their cognitive health is moving. And in doing so, you can sort of see what are some risk factors that they may have that can be lessened, perhaps by lifestyle changes and other things that were mentioned. And also, what are some other factors, as Dr. Burns was referencing, and those can be things like genetics that we don't have any control over, right? Or just kind of the luck of the draw. So in some ways, yes, we do a risk factor analysis, but also I'm really focused on like how are we today, and then how can we best provide the supports that that person needs today and looking into the future.
So earlier this year, researchers in the UK published their findings on a new dementia risk score. An analysis published in the British Medical Journal found that their format outperformed all the other risk scores, part of which we just mentioned. However, since their data used people from the UK, they say that score only makes sense in the UK. So Dr. Burns, how much does this geographic location play into dementia, and do you agree that that data is not applicable to other areas?
I mean, we can learn a lot from that, but it is important to make sure we have a good sort of generalizable population that we're studying, and that's an example of just individuals from England who are may not represent who lives in America, and what sort of be a little more concrete. The way to think about this is sort of racial and ethnic differences, and we know Latinos and African Americans are at a higher risk of developing Alzheimer's disease, and we need to understand why. But that fact, sort of means, these kind of predictive tools may be different in one population versus another.
Okay, now you just said the phrase Alzheimer's disease. Let's kind of jump back for a second. Dementia, Alzheimer's disease. Help us understand the difference, or is there really a difference?
Yeah, so there is a difference, and they're interrelated. So dementia is a broad term that simply means memory and thinking changes that are new and that interfere with daily function, so that people are having more trouble doing the things they've been accustomed to doing, their whole life. Now they're having problems doing it because of memory and thinking problems. So dementia is a broad term. It's a syndrome, and it has many causes. Alzheimer's is one of the causes, and the most common cause. The number one cause of dementia is Alzheimer's. Probably 2/3 of dementia is related to Alzheimer's. And when we define that, maybe your next question, it's the presence of plaques and tangles in the brain in somebody who has dementia. So scientifically, that's how we're trying to define
So Alzheimer's is like a subset of dementia. Dementia is this big,
Exactly.
broad, hairy category, and Alzheimer's say, well, you got plaques and tangles. We're going to call this one Alzheimer's, but these others may be due to other causes, Lewy body and all sorts of funny stuff, normal pressure hydrocephalus, all sorts of different things that cause dementia. Is that right?
Exactly. Yep.
And so, how do you know then if the risk factors, like, well, what would you say is a more common-looking risk profile? Like, does family history of it make a big difference?
Well, so Dr. Callinger, Rich just mentioned age and genetics, and those are the number 1 and 2 most common risk factor, or strongest risk factors. The older you are, the higher your risk, and if you have a family history, that's an increase of your risk. Now, it's complex. There's another sort of complexity here. If you have a family history, meaning if your parents or brother or sister have had Alzheimer's disease, you're at higher risk. But it doesn't mean you're destined for it. So not everybody with a family history develops Alzheimer's or dementia, and not everybody who gets Alzheimer's and dementia has a family history. And so it's kind of a weak but a very real and actually one of the strongest risk factors for developing dementia.
So just as a thought, help us understand a little bit better. What's normal aging look like? I was talking before the program, when I went in college, I did like 4 semesters of calculus, differential equations, PChem. I thought it was fun, hard, but fun. I'm not sure I can still do that anymore. Maybe that's a lack of practice. Maybe is it aging decline? I mean, how much should you experience as a normal part of aging?
Well, yeah, aging brings a lot of changes, and kind of the same way we think about it. We don't run as fast as we did when we were in our prime. You're still in your prime?
Yeah, no, not at all.
Yeah, so we don't run as fast. We also don't think as fast, and we may not be quite as adept at some complex things as when we were younger. But with aging, I mean, we should see stability in sort of daily function tasks. So one of the big differentiators that we look for is, are we seeing problems and things that somebody did well before? You know, if we're starting to see problems in the things that somebody did well before, then that's a big red flag for this. You know, that's not what we expect with normal aging. And so that's kind of our differentiator, at least in the memory clinic world. It's interference with daily function. We don't expect that with age, but we do see changes with age. We see slower thinking. We see a little bit changes in working memory, the ability to hold information in your head and act on it. The prior example from 20 years ago that I used to use for this was, you look something up in the phone book and you have to walk across the room and pick the phone up and dial it, which we don't have to do that anymore, but that's working memory. You hold that information in your head temporarily and then act on it. And we use working memory all the time, and our working memory is a little less efficient as we get older. And those are things that we can measure, but they don't really interfere with daily function. They're kind of a nuisance.
So it's really this daily function thing that is a big part of it. So Dr. Counterich, what do you do to talk to your patients and say, I need you to, let's work on your brain health a little bit?
Yeah, so I think it speaks a lot to the risk factors that were brought up earlier, right? So social isolation, we want to really have people get out into the world and interact with other people, right? We also want to have people moving their bodies, because moving your body lessens your risk factors for heart disease, which then lessens your risk factor for many of the other heart disease, obesity, and other pieces that can increase your risk factor for cognitive problems and dementia. And really just also this idea of like continuing to use your brain. So like ongoing learning, whether it's reading or doing crossword puzzles or, just continuing to use the things that we have allow us to continue to have those abilities longer for many people.
Isn't it true that exercise still makes a big difference?
Absolutely.
Throughout your entire life? I think it's more important as you get older than when you're younger. Your ability to be resilient, I think, declines a little as we get aged.
Absolutely.
Is that a fair statement?
Absolutely.
And you have to devote a little more time to taking care of yourself than you did when you were younger, huh? So let's switch gears from predicting dementia to detecting dementia. And this is where Jill comes in. Oh, wait a minute. Does that sound right or wrong? Our colleague, Jill Chadwick, recently took the SAGE test. I love that name, by the way. That's a self-administered gerocognitive examination. Did I say that correctly?
Yep.
See, okay, I think that by itself means I scored well on a test. It takes about 15 minutes and asks patients a variety of questions, like labeling pictures, simple math, and drawing images. The goal is to detect the signs of dementia. Jill, overall, how did you feel about taking the test?
Well, it changed. Going into it, I felt great. And primarily because Alexis Del Cid, who you will see a little bit later in this program, who is also about 15 years younger than me, kept saying,
are you blaming it on age?
She kept saying, it's easy. You're going to sail right through it. It's not any problem at all. And anybody who knows me, which is almost everybody that works with me, knows that I'm a 4.0 kind of girl. I got to have that A. A minus isn't good enough. A plus is better, right? So I'm trucking along, and as we're going to talk about, there was one task that I was asked to do that really bothered me. So I chased Dr. Burns down in the hall before we came out here, and I said, if you tell me that I'm okay, we can talk about it. So we can talk about it.
So she tell her she's okay? Because I think she had some trouble drawing the numbers on a clock face.
I did. It said, draw a clock face. And I'm like, okay, I knew where the 12 was, I knew where the 15, 6, all that kind of thing. But I'm like, what numbers do I use? I mean, I think about a clock face in terms of cooking, honestly. And even though my clock that's on my stove, that's on my wrist, is all spelled out digitally, in my mind, it's like, oh, if I've got 5 minutes or 20 minutes, I do think about it, but to sit down and draw it, I couldn't do it. And it really has bothered me.
So that means you weren't 4.0 is what I hear you saying.
Yeah, rub it in.
Okay, so Dr. Burns, any notes on Jill's test? Is she really still a 4.0 student?
She is a 4.0. Yeah. No.
So tell me about why it would be different, though.
Yeah, I mean, so this is a great example of why the limits of these kinds of tests. You start with the sort of context, and is Jill having problems in her day-to-day function? I know she is not. She's doing great in
She
her.
still yells at me from time to time.
I never yell at you. But I do have some of the same things. You and I are kind of contemporaries.
Yes.
And although I'm pretty sure you're older than me, but we won't have to talk about that right now. But I have the same problem with recall, or I guess what Dr. Burns just labeled working memory. But I still have the ability to figure things out. And I will have to tell you that as a reporter, not being able to remember things is very unsettling, because your whole life is about you hear something and the ability to turn around, take a microphone, and then say something to your audience and help explain a story. And not being able to remember how I memorized how I was going to get into my story, or to remember someone's name, is really unsettling day to day. In fact, my employees could tell you that I will bring them in and I will say, okay, Stu, I need to talk to you. And by the time he gets in my office, I'll go, I hate my brain. I go, walk back out and I'll remember it. And I do. And I can usually figure out a workaround. But sometimes when you get frustrated, you just yell at somebody. No, I don't yell.
As I said, when she
say
yells
very
at me, I think
loudly.
she's still cognitively
I
intact.
bellow. Does anybody remember the doctor's name? Who? And then I describe it. Right? So those kind of things are
Does that make
not
you feel
fun.
like she's got early dementia, or does it make you feel like that's just kind of normal age?
That's normal.
Thank
I would
God,
say
because I can never remember anybody's name.
a normal score on this test is not perfect. It means everybody's allowed to miss a few points, and it's because everybody's different and built differently. And I look at this and I say, okay, maybe you're not into the visuospatial stuff, and you're probably a word person.
Which is true.
Which, look at your job, you're a word person. And so, this is a normal test where you missed a couple on the spatial stuff, and some people are just built that way. I mean, and we know everybody's built differently. Some people are much more sort of spatial, and some people are more words, and we see that in the testing that we do.
Yeah, I also liked what Dr. Calendar Rich said as we were coming out. I had to, I can count change. People, I can do it. But they has a question on there that you have to count it. And I was telling them how I was taking it and crossing out my zeros and carrying my 1 over. I was doing math.
Front of the class, in the front seat, hand up. That's who you were, wasn't it?
Yeah, I
okay.
was.
Now we know who she is.
But what I appreciated is that, I used to be able to, the clock question came before the math question, I think. And that clock kind of unsettled me. So when it came to the counting change, I wasn't going to miss the question. So I worked the problem out. And I really appreciated what you said, Dr. Calendar Rich. So tell the whole class what you told me.
We don't count change anymore. Right? Everyone's charging everything, and we don't write checks anymore so much. We don't count change anymore. And frankly, we don't look at that many clock faces anymore. And perhaps Dr. Burns has more information on what the future sort of looks like for testing using these types of models, but the truth is the tests we use right now are becoming less and less applicable.
So what do you tell your patients when they come in and they didn't do as well on a test? And do you use this age test, by the way?
I don't.
Yeah, but is there any test you use to help with dementia, to help kind of say, let me test to see how you're doing?
Oh, absolutely. There are other tests that we use, whether they're screening tests or tests to actually, define that someone has a dementia or cognitive problem. Those tests are really used for us to see, again, like where we are. And then as more new therapeutics come out, we'll be able to then help differentiate people to the right places to get treatments that are available.
Jill, first of all, thank you for being so open, honest, and candid. And we're going to take a poll after the program to see how many people think she yells. I'm just saying. She doesn't yell. Thank you.
Yeah,
Thanks for being
I might yell after this.
You did great. All right. So how do you guys assess mild cognitive impairment? Let's define what that is. It's kind of a precursor to dementia. How do you guys define that?
Well, it is a precursor to dementia, and it is cognitive change that doesn't yet interfere with daily function. So we've been talking a lot about daily function, but it's cognitive changes that we're seeing, that we're observing, and that we're measuring. We can actually see, a profile that suggests cognitive change. And so when we see that, we observe cognitive change, but we don't see yet any interference with daily function. Then we call it mild cognitive impairment. And so Cognitive change. I don't think Jill's changed. So
Right.
she does not have MCI. Maybe we could say her visuospatial is, she's maybe got a C on that. But she doesn't have mild cognitive impairment because it's not a change for her. She's a word person, and she would probably always have had trouble with that. Or she, as Dr. Callender-Rich said, we don't look at clock faces. So we can't interpret these kinds of tests. At face value, we have to sort of think about the context. And with MCI, we're thinking about the context. Are we seeing cognitive change? And then, there's sort of that line of does it interfere with daily function or not?
It's funny because I just, and I was just going to say, as she was saying, I had a little trouble with clock. I said, can I still draw a clock face? I had to stop and think about whether I could do it.
And I think I should just add that while mild cognitive impairment is a precursor, not everyone who has mild cognitive impairment progresses to dementia. And so it's something that we want to follow closely, but not something that really sentences you to that diagnosis.
Thank you. Very important point.
And you think about all the vascular changes that can happen and from smokers and things like that, and we know that they don't get enough blood flow to the brain, and that leads to some cognitive impairment. All these things can mix in together, right? And it's like, if you want to avoid it, the best thing you can do is, take care of yourself.
Absolutely, and that really is from early ages to middle ages and moving on. It's something that we can think about in our 30s and 40s and 50s, even before we get to the point where you're seeing somebody like me.
And I think in the last couple of weeks there's been some stuff that hit the popular media that sleep impairment often leads to more trouble with cognitive function. And it wasn't so much about how much you slept, it was more about how regularly you slept. Did you sleep in the same hours? You didn't have a schedule that jumped around a lot. Talk to us about the impact of sleep on cognition.
I mean, there's pretty good data out there to show that sleep is critically important to your brain health. And it's about good sleep, it's about treating sleep apnea, and it's about really ensuring that time of sleep is a time in which your body can reset itself. And you're right, there's some studies about it being at the same time and starting at the same time and ending at the same time. There are also studies out there that suggest that the number of hours is important. So I would say that what's very important, at least from my perspective, is when you wake up, are you well rested and are you ready to go?
Right on. Right on.
That's right.
Good
and
sleep.
I think it's hard to know because everybody's just built a little differently, and we try to generalize it all, but the reality is it's much more about the individual, making sure they feel good. When people feel good, they tend to do good, as I so rightly tell all my patients. All right, well, we're here to answer your questions. Send them in to with the info on your screen. That includes the chat on YouTube or Facebook, the X platform, or emailing the Medical News Network. Let's check in with Doc Hawk. Dr. Hawkinson, how are the COVID numbers?
Well, still a little bit high, but better than they were last week. We've kind of seen up and down, getting up to the mid-20s. We had 22 last week, 19 this week, and overall our COVID testing has increased from about 600 the week prior to about 800 last week. So overall, we know people are getting some sort of respiratory illness and coming in for testing. We've seen that across the board.
The Wall Street Journal this morning, they had an article about talking about JN1 and the rapid rise in wastewater testing, already a 10% rise in hospitalizations across the country. This is going to be a wave, or what we used to call a wavelet, I think.
Yeah, I mean, certainly it could be. I think we are always ready for it. We always have to be watching it. But we know that with individual immunity, either through vaccination and or infection, and also then community immunity, we know that still the people that remain the highest risk of severe disease and hospitalization remain those with comorbid conditions, things like heart disease, lung disease, kidney disease, immunosuppression, and of course, age is always one of the biggest factors as well. But in addition to COVID that we have to be watching for, and SARS-CoV-2 and the variants, right now it doesn't look like there is any difference fundamentally in the virus other than maybe some spike changes, so not really causing any new severe disease or anything like that. We also have to be wary of the other viruses out there, and we've heard the past couple of years, triple-demic. We are always concerned in monitoring for that. Our health system is always prepared for that, but we also have to make sure that we are aware of those things, especially RSV for those most at risk, the very young and the elderly, and then of course influenza as well.
And you have some graphs, I don't know if we've shown those yet, that show the jump in our flu inpatients, RSV, and COVID inpatients.
Yeah, and I think just as I mentioned, the COVID testing increased, so did our overall influenza testing. Here we have influenza tests, and you can see last week was the farthest graph bar on the right there, and you can see how it jumped. So we had a significant increase in the number of tests, the positive tests, and the percent positive as well. We had 664 tests in that final week there. That is up from 480 the week before. So overall, we also have increased admissions as well for influenza. We had 14 influenza inpatients in the past week. But also you can see the significant jump and increase in those hospitalized patients. And then of course we talked about RSV as well. So RSV testing also increased, went from 448 tests the week prior. And then if you look on that far right-hand bar, that is inpatients. But overall, we have to say that the testing increased as well, over 600 tests. And you can see the RSV inpatients. We have 8 total RSV inpatients, and this is across the health system. So this is at places like Indian Creek, Strawberry Hill, Marillac, and of course here at the main campus. We have 8 RSV admissions, and 5 of those are adults, and 3 of those are pediatric patients.
So we're really seeing kind of what we would expect to see in the winter.
Yeah.
You know, if we had 19 COVID admissions, 14 influenza admissions, and 8, or I think it was 9 RSV admissions, we're seeing an uptick on all of those, which is not surprising to us, is what we would expect. A couple of good pieces of news. We think that the vaccination for COVID still is effective, and even against the new JN1 variant. Secondly, we just point out, though, and hopefully this shows no cognitive impairment, because I read this at 6 a.m. this morning, but only 16% of eligible Americans have gotten the COVID booster shot, and it still works, people. So another good reason to go get it, Hawkeye.
I think so. You know, we have good data to support that fact. Again, if you've had COVID recently, we have been recommending waiting about 3 months from that acute illness to get that booster. But we now, I think, are getting into the throes of respiratory viral season. Now we are really seeing those colder temperatures. We have been dealing with more get-togethers, especially since Thanksgiving. And so we're really looking at this time period till about February to see if we reach our peak. Don't know when that will be and what that peak will be, but we are always prepared here at the health system for that.
And just to say, you know what we didn't have any of last week? People being admitted as a result of side effects of the COVID vaccination, the RSV vaccination, or the influenza vaccination. That number is 0.
And I think I just saw a article about looking at data on people who received both RSV vaccine with flu vaccine, and it was safe as well. So
yeah, and hey, Travis Kelsey, thanks for that. I love that ad he did.
Yeah.
All right, Alexis Del Cid is watching for questions from our community. Alexis.
We have a great one from Yen Liang. Yen wants to know if there is any sort of correlation between a weaker immune function and dementia. Do people with Alzheimer's dementia get sick more often?
I don't know of one.
I've not heard that either, unless you're sick and you're isolated and you have other challenges from being sick. I don't know if it's an immune system so much as if you have other sources of chronic disease.
Yeah, good. Yes, exactly.
Yen also has a follow-up to that. He wants to know, how do you determine between just regular age-related, your mind slips on some things with age, and dementia? A clinical diagnosis.
I think that was a hard question earlier, and I think we settled on, did it affect your basic ability to function?
Right, like are you still able to do the things that you have always done? If you're someone who cooks complicated recipes, can you still cook those recipes? If you're someone who does woodworking, can you still make that thing that you've been making? Or doing the bills, things like that. Like the things that you do for daily function and independence, those are the things that we wonder about and we watch for to make sure that someone's cognition has not moved forward into like a dementia or mild cognitive impairment.
Is it fair to say that those things which require high levels of complex processing all at once, we think about driving. You know, there's a lot of spatial awareness has to go with driving. Are you as good a driver when you're 65 as when you were 25? You may be a more cautious driver, but I think there's a lot of data. Your reaction time is not quite as good. You don't see a lot of old race car drivers.
I mean, with normal aging, certainly there are things that change related to reaction times and also just the speed at which you process information. And you're right, driving requires you to look, to move, to hear, to see, and then to incorporate all of that information into a very rapid decision-making process. So we know that people, even with normal aging, do have some changes in their ability to drive and their ability to drive safely. Most of that can be compensated for. What we see, though, even in very mild dementia, is that driving can become a bigger deal very early, and probably earlier than we think about.
That's so
Alexis.
interesting. We noticed that with my dad. My dad has Alzheimer's. We've talked about this, but a few years before he was diagnosed, he started driving so slowly, like a turtle, and he could not figure out where to go. He had hard time navigating. Jeremy Yenser has a question. He wants to know, this is interesting. He writes, I've heard you can use AI to help analyze dementia and virtual reality to help manage symptoms and quality of life for people with dementia. Is there any truth to this, or is this just the internet being the internet?
Okay, go for that one.
Yeah, I mean, AI and machine learning tools are really going to be helpful in these types of developing these types of predictive tools. So there's a lot of people, including people here at KU, focused on, can we get these huge data sets and run machine learning and AI on those data sets to figure out what's the best predictive, combination of all these risk factors to put a number on somebody's risk for the long term. So it's going to have a huge impact on sort of analysis and predictive tools in the future. And then as far as virtual reality, there's a lot of interest in tools like that. These are things that are years out. But I'd say there is a future where we'll be using some virtual reality, training and or brain games and things to try to impact dementia and dementia risk. But it's a ways out.
So can I just ask you a question about the topic brain games? Like I try to do some numbers games. I felt like, okay, is that helping me prevent dementia because I'm trying to exercise my brain? I know the brain's not really a muscle. Talk to me about that.
I mean, I think the more you use your brain, the better off your brain is at sort of connecting the different pieces of the puzzle, right? That said, do we think that doing brain games and crosswords is going to really prevent dementia in someone who was going to develop dementia? Probably not. It may slow it down a little bit, but it's really hard to say. What we do know is that doing those things allows a person to have activities, and activities are good, and that we should always use our brain to the best that we can.
Yep.
Anything else?
Yeah.
Is there a microchip that's going to come I'm going to plug in to help me with my brain and my ability to do calculations?
Boy, maybe some. I mean, ask
Okay,
Elon Musk.
you're not helping me.
Do you really want that?
Oh, man.
Do you want? Yeah.
Nope, he'll be trying to control my brain. Okay.
Joellen has
Alexis?
a great question. Joellen writes, my grandma died at the age of 88, and in her final 5 years, this is Joellen's, where Joellen writes, she was really batty. I seem to also remember something about the hardening of the arteries. Could the hardening of the arteries and her behavior the last 5 years of her life been linked to Alzheimer's?
What do you think?
So yes and no. Absolutely, there are, Dr. Burns talked about this umbrella term of dementia. There are lots of different kinds of dementia. We know that most dementia is an Alzheimer's type of dementia, but we also know that there are many other types, including vascular dementia and others that Dr. Stites mentioned earlier. People who have more cardiovascular disease are at higher risk for this type of vascular dementia, in addition to other cognitive changes over time. So the answer is yes, it could be related. Hard to say now, but certainly there's a possibility.
We have another question about amyloid proteins, and that related to the research. I'm going to weave in, we got a couple of questions about that. Yen wants to know if there was a recent controversy in amyloid protein related research, and then Lina wants to know, why is it hard to say with certainty amyloid plaque causes Alzheimer's versus being linked to Alzheimer's? So I guess could you talk about the controversy first? Was there a controversy, Yen wants to know?
Yeah, there was a controversy where someone, I guess, maybe falsified some data, and it got a lot of news in the science world. It didn't really have a big impact, I'd say, on sort of misleading the scientific world, which is what the press sort of, the story that was told. It might have misled a few people, but But there has been a huge focus on amyloid, and there would have been, and actually that focus has resulted in new drugs that target amyloid and have an impact in slowing it down in the early stages for certain people. So yeah, some controversy, but maybe overblown a little bit.
And then does amyloid plaque, on Lina's question, is it just linked to Alzheimer's, or can you say it causes Alzheimer's?
Well, that's the big question. Is it the smoke or is it the fire? For a long time we thought if we could go after amyloid with like these new drugs that we've spent decades getting to the point where we can now prescribe them, if we were able to pull amyloid out of the brain, we thought maybe we could cure Alzheimer's if it was the fire that caused all the problems. We can now pull amyloid out of the brain, and it doesn't cure Alzheimer's, but it does slow it down. And so it's in this, it's part of the chain or the cascade of problems that we see in Alzheimer's. It's a really complex disease, but it's not as simple as amyloid. And we'll be debating for a long time, is it the cause or the consequence of the disease? But what we do know now is that we can target amyloid, and by targeting amyloid in certain people, we can slow it down.
It's like so many controversies in medicine. We think it's this, and then the more we learn, the more we realize we have to learn. And I'm always impressed at the complicated nature of the human body and what a phenomenal design, brilliance, put together, how it works, and all the redundant systems it has to try and protect itself. It's really remarkable, and as a result, disease is rarely one thing.
Sharon has a personal question. Sharon writes, I'm 76, I had a stroke in December of 2019 and then severe COVID in 2020. Will this make me more likely to develop dementia?
Well, I guess I would say maybe, but just a little. Like, I wouldn't live in fear of it because you've had those things. But, we know if we look at 1,000 people we segregate those who have had a stroke, and maybe those who've had severe COVID, that group is probably a little bit higher risk than the group that doesn't have those risks. So small, but not something that I'd be worried about.
Ruth Allen has a great question. She wants to know if there are studies indicating that the elderly are better taken care of in some countries versus other countries.
Oh, that is a sticky question.
I want to hear you answer this one.
Yeah, I would say that different cultures have different ways in which family units work. And there are many cultures around the world where it's very normal to have multi-generational households and perhaps a more one-on-one family direct care of older adults. And there are other countries or other cultures like the US where perhaps some of that care is outsourced, and that's because of a lot of different things related to our work culture here, and it's not an intentional push the older adult to the side by any means. So yes, there are differences. I would not necessarily say that those differences are good or bad. And that's because you can have family members who are very well-intentioned who may not be able to have the resources to provide the care that someone needs. And you may have paid caregivers who in another setting really can provide all of those resources and can actually be as good, if not better. And so I would say it's different, but one is not the best and the worst.
Okay. We have a question from Pat. Pat has a question about the test or any other tests that you use to diagnose there might be possible cognitive impairment. We talked about the SAGE test, which Jill took at the beginning of the program. We talked about that. Pat wants to know if there are any other tests available right now someone can request so they can discuss brain health with their doctor.
Well,
is SAGE the gold standard, or are there better tests?
SAGE, there's really no gold standard when it comes to the sort of cognitive testing. That's why you need, to talk to your doctor. And when it comes to sort of cognitive function and testing that, you need to take it in context, and the history, the story around what's changed and all that's really important. And then the numbers can help a doctor make that distinction. Is there a big red flag up like MCI, or are we in a dementia zone? But what's coming fast are biomarkers, we call them. So blood measures, spinal fluid measures, brain scans that can tell us now, and these blood measures are coming very fast. We're doing them today on the research side at our Alzheimer's Disease Research Center, and we're working to get those into our clinic. But they are measures that can tell us predictive, tell us, with high probability that somebody has amyloid in their brain or the tangles in their brain. And so I'd say 5 years from now, it's going to be very different in terms of understanding risk. We're going to add these biomarkers to these predictive models that look at risk factors, add the biomarkers to really get better at stratifying an individual for high risk, medium risk, low risk. And so things are changing by the day right now.
What I would say is that is going to be a remarkable time, because it also is when you can start building the science more to help you address it, because you can see it so much earlier. We all know if you can detect disease early, you can usually intervene a lot better.
Yeah, and I think as we have those more tools to identify disease early, hopefully near the same time we will also have more and better tools to treat the disease early, because I think what we can all agree on is if we don't have something to do about it, it can be very difficult to know that we have high probability of a disease that may not be coming.
Yeah, that's a great point. I mean, the value of a screening test and the value of a biomarker is only as good as what are we going to do with that information. Can we act on it? Can we do something to delay the onset? Can we stop the process? And so we are working on those things as well, and our hope is, we'll be there. But I wouldn't recommend the SAGE for everybody who's watching, because it can make you, it can maybe have more negative effect, angst and anxiety when you shouldn't be worried, and not necessarily something we're going to do about it. So the idea of screening the population is something that we don't really recommend right now, but I do think maybe 10 years from now, when we have interventions that are proven to prevent and better treat dementia and Alzheimer's, then we will be doing population-wide screening programs.
Well, 10 years from now, I'll be about 75, and I'm going to hope that I can still do my cognitive tests and all my brain games and everything else. Hey, this has been a great discussion. Final thoughts from our guest today. Dr. Calendar-Rich.
I think it's kind of a theme I have every time that I'm here, right? We can do things at all stages of the game to help prevent problems in the future. There are modifiable risk factors here, and we should really just do our best to work towards a healthy lifestyle now to prevent whatever we can later.
Yeah, great. I mean, I'd say, yeah, you do have some power over this. I mean, we're working on defining how much, and it's limited, but what you do with your lifestyle is important. Exercise, eat right, keep your brain active, and we think that does translate into a lower risk. So be sort of ambitious about working against risk of Alzheimer's, and start early. And then I'll just say this, I just kind of alluded to it. I think the day is coming. Get involved in research if you're interested, and help us get to that day where we're going to be able to spot the changes before the onset and do something to prevent it. And that day will come, I believe. It's not a question of if, it's a question of when. I don't know if it's 10 years, I don't know if it's 30, but that day will come.
Yeah, I like to say clinical trials isn't just research, clinical trials is therapy. Because when you get involved in those kind of things, you're developing the next new thing. Hawk.
Yeah, I think would echo our guests, and it is about healthy lifestyle. We were asked very early on, what can I do to increase my immune system? And it's that healthy lifestyle. It is getting good sleep, getting good nutrition, doing those preventive measures with vaccination, keeping your overall health good. And it's working with your medical teams. I understand people don't necessarily have easy access to medical teams. Work with your communities to try and get that access, to get a primary care provider, get a medical team so you can develop a healthy lifestyle. You can start at any time, and all of that will help make a difference in the future.
We talk a lot in this program about the power of faith, hope, and science. There's another power in this room, that's that power of you. You want to have a better life? Part of what you do is make good choices. We've talked a lot about them on this program, but the power of you is really, really strong. And while we can rely on faith, hope, and science to help deliver us and help treat these things like Alzheimer's and mild cognitive impairment and dementia, it really starts with the power of you. Thanks everyone for watching and listening. We'll see you next week.
A mother's intuition. When doctors pushed her aside, this mom demanded a second opinion, and it saved her daughter's life. I'm Alexis Del Cid on the next All Things Heart, the life-saving treatment she found for her baby right here at the health system.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.